So here we're going to set up our patient for spirometry, and I'm showing you some of the equipment we're going to use here. This is the spirometer. This is a small processing bedside version. Here's the microprocessor, and of course our bacterial filter with a nose clip that helps them only breathe out of their mouth. So all of these devices can be found in a spirometry set. Actually, they come together, and I want to show you all a little bit about the setup for the device. So we're doing a forced spirometry, that icon right there in the middle. Kind of getting focused here, and there's some patient data that we're going to put in to help the spirometer understand a little bit more about what our values are going to mean. So of course you know that Mrs. Tubbs is a female. She is African American. We're going to select black for that. We also have her height. Now keep in mind her height is coming from her patient information that tells us that she's 5'4" or 64 inches. She had a weight of, let's see, I believe from her patient data it was 140, so 140 pounds. And of course we know her age was 54, so we're going to type that in there. And that is the end. We're going to actually accept that. And here you'll see the actual setup for our spirogram. So let's get started with Lucy and see how she does, okay? So here we are with our pretend patient, Miss Lucy, and I'm showing her the different equipment that we're going to use, as well as explaining to her their purpose. Of course, the bacterial filters for sanitation reasons. It'll go inside that microprocessing unit for her to breathe into, and we just slide that in there. And of course, you know, I want her to make a good seal with her lips so that all of her air, when she's making her effort, goes into the device for detection. And there's actually some nose clips that come in those packages, and what those are for, of course, to clip onto the nose, but it's to keep air from coming out of the nose, so that all of our air effort out of the lungs is going to go into that device. So we want to be able to hopefully get a full accurate reading that way. Of course, those nose clips are kind of hard to put on and they pinch real tight, so we're going to give Miss Lucy just a second to get those on her nose. But this is, of course, is a bedside spirometry. This is not the huge, large 3 milliliter syringe one that we sometimes see in hospitals. But this is just as effective. So she got it on her nose. Great job. And I'm having her at this time place the device in her mouth, and I want her again make a good seal. It's very important. That really can mess up your results, give you some erroneous readings if patients do not know how to make good effort, have good timing, or have a good seal. So I'm explaining to her that she's going to take a series of normal breaths, about 3 or so, and then after her last exhalation of a normal breath, take a huge breath in, and then blow it out as fast as she can, and keep blowing and blowing and blowing and blowing until I tell her to stop, or until she can no longer breathe out at all. So I'm holding the processor. I'm going to document some of the changes, and I'm having her begin. She's taking that big breath in, and of course, you know, your patients sometimes may make mistakes, so you cue them. You encourage them to follow directions, and of course it's a timing thing. It takes a little bit of time to actually get accustomed to breathing in through the machine and knowing when exactly to do what you're supposed to. So I'm having her breathe normally in and out, and of course, you know, there's no shame in having an error, but she's making her first attempt here. I'm encouraging her to blow as hard as she can, to keep going and keep going, and take that normal breath, and we'll see what her first results were. Now, I was the one there actually looking at it, and I can tell you from being there with Miss Lucy that it was not the best first effort. That's okay. That happens. You know, you're getting familiar with your own body as you're having to do a test, and sometimes you need to realize, well, I need to time a little better. I need to push a little harder. So we're going through it again with her here. She's taking her big breath in, and she's blowing out as hard as she can, but if you notice, her breath is kind of coming out a little bit too slow. And that will be indicated probably at the end of the test. It'll tell me poor patient effort or slow start, something in that manner. But this is just to get Lucy familiar with what we're going to do with our patient. So 3 tries, you know, to get an attempt that will work is what we standardly will do. And if nothing is working, of course, we want to give our patient a break. That's a lot of heavy breathing, but we're going to have her go again. I'm just re-instructing her, tight seal with the lip, make sure you're breathing in timely, and consistently try to breathe in maximally and exhale forcefully and fast. Because of course this is a forced vital capacity. We want them to have a good effort. So Lucy here is going to go one more time, getting her used to it. Okay, she's taking that huge breath in again, blowing it all out, and she's not quite getting the fact that you're going to have to blow a little faster, but that's okay. That's what learning is for. So we're going to access her data, and let's actually look and see how she did. We'll also do one more test and show you what is done on the actual spirometer handheld device. So let's take a look here.
Understand better how this is such a valuable tool in the diagnosis of COPD. So how often do you check it?
So actually, it's assessed on an as-needed basis. So as our patients, like we said, we want them to come in less than 12 months or a year. We want to assess that periodically, of course, but then also if our patient comes in with an exacerbation, we want to reassess again. So actually, I want to talk to you a little bit about some of our goals as respiratory therapists. We don't just go into the hospital and um, hope to make a difference. We have specific things we want to achieve. We call them goals or protocols, and things such as that have been written out actually by Gold in that pocket guide. So let's go over a few of those details. So the actual goals of COPD assessment are to determine the severity of the disease, its impact on the patient's health, and the risk of future events. And that includes exacerbations, hospitalizations, and even death. So, in order to give a guide for our therapy, so of course, we are going to assess the following aspects of the disease separately, but also very accurately as much as we can. First, the symptoms, and then the degree of airflow limitation using spirometry, like we just did. Okay, and also we're going to assess the risks of exacerbations and comorbidities. Okay, so there are actually certain things from Gold that help us understand a little bit more about how we're going to address our patients' symptoms. So I actually pulled up the guides that we're going to use right here. So I want to go from the pocket guide though. We're actually going to use these questionnaires. So symptoms are assessed by validated questionnaires from the COPD Assessment Test, or CAT, as well as the Clinical COPD Questionnaire, or CCQ, and they're recommended for a comprehensive assessment of symptoms. So putting all the symptoms that we've taken as a version from our patient, putting it all together. We also can use the Modified British Medical Research Council, or MMRC's, scale, which provides only the assessment of breathlessness. Okay, so actually I have one of the questionnaires right here for you. I pulled it up for you. And you can see this is some of the things that we're going to look at when we're helping our patient, and we're determining on our side as the therapist where our patient is in terms of severity and how we can help treat them. So when we're assessing the risks of exacerbation, and keep in mind an exacerbation of COPD is defined as an acute event characterized by a worsening of the patient's respiratory symptoms that is beyond normal day-to-day variations and will lead to a change in medications. Okay? The best predictor of having frequent exacerbations, and that's 2 or more a year, is a history of previously treated events. So the risk of exacerbation will also increase as airflow limitations worsen. Now, hospitalization for a COPD exacerbation is associated with a poor prognosis and with an increased risk of death. Okay, so like I mentioned before, Mrs. Tubbs has been here several times, and of course that's a big concern for us. That means we may need to modify how she's managing, or more stringently monitor some of her risk factors. So I also want to go over a little bit about some of the other aspects that play into the assessment. Of course, a person's pulmonary system in the chest is one major part of how they will function. Of course, that ventilation and oxygenation, core major life functions. But there are other organs in the body that can play a role. So I want to go to this next page here. Don't forget that part about comorbidities. It includes cardiovascular diseases, osteoporosis, depression and anxiety, skeletal muscle dysfunction, metabolic syndrome, and lung cancer, among other diseases, can occur frequently in COPD patients. So these comorbid conditions can influence mortality and hospitalizations and should be looked for routinely and treated appropriately. So this is something we take very seriously here, especially for patients who are getting older. Their risk factor goes up significantly. So let's continue by going over some of the last portions in our COPD management, okay?
Okay.